can you reverse the diabetic state or limit progression from pre-diabetes to diabetes by non-pharmacological interventions? The answer is uncategorically yes. I think the importance of things like the DIRECT trial is that what it shows is that if you get in early and you hit it hard with weight loss, and it's not a simple thing to do, that actually you can reverse this condition and you can get rid of it. But it is a message of hope. Mm-hmm. And then in terms of prevention for people with pre-diabetes, uncategorically the case that behavioral interventions which target essentially 5 things, normalizing body weight, increasing physical activity, changing diet in the sense of reducing the total amount of fat, reducing saturated fat, and increasing fiber. If interventions that target those things roughly halve the likelihood of progression from pre-diabetes to diabetes. So again, a message of hope. When they say, "What should I do, doctor? Should I do this diet or that diet?" Or I think the answer is you should do whatever you're capable of doing, and whatever diet or behavior change you think you can sustain.
Nick, thanks a lot for taking the time and joining our podcast, and very happy to have you here.
Well, it's my pleasure to join you, Dmitry.
Nick, can you share with our viewers your background, please?
Sure can. So I went to medical school in the early 1980s in London and qualified as a physician, worked in general medicine in and around London, and at that point got very interested in diabetes care and actually got interested in trying to understand why people were still getting complications of diabetes, even though we knew how to treat it well. So I thought that was an injustice, and that's kind of driven me from that. And then I did cardiology, and to be honest, got frustrated with the fact that we put all our effort and attention and our brain power in dealing with people who are who are a long way down the line in terms of having complications of disease. And it gets a bit frustrating when you do that all weekend and then on the Monday morning you do a cardiology clinic and you're dealing with smokers and you think, well, hang on a minute, or the effort's being put in the wrong place. So I moved to doing public health, did that as a secondary sort of career, and then did a fellowship in Harvard at the School of Public Health, having done a master's in London, the London School of Hygiene and Tropical Medicine. Then started my academic career in Cambridge, did a PhD, and then developed my research on essentially understanding the causes of diabetes and trying to translate that into preventive action, and been doing that ever since.
Wow, impressive career. And you are managing quite a big team of epidemiologists in Cambridge these days, right?
Yeah, that's correct. A couple of hundred people, and
wow.
No, it's an important topic, and I've managed to combine doing clinics with doing research on prevention, because I think sometimes people who are interested in prevention forget that there are sick people who need treating today. And then sometimes people who are firmly involved in only treating people forget that there are things we should do about prevention. So having a combined career has been good for me.
Okay, got it. Thanks.
Can we reverse diabetic or pre-diabetic condition by just changing our lifestyle without any medication, such as intermittent fasting or different kind of diet?
Yeah, no. So the question is, can you reverse the diabetic state or limit progression from pre-diabetes to diabetes by non-pharmacological interventions? The answer is uncategorically yes. So in people with established diabetes, if you do early weight loss therapies, non-pharmacological, so behavioral interventions with essentially very low calorie diets. The direct trial has shown that those people who have diabetes can reverse to normal. So it is possible to reverse diabetes, and that is a big shift in our thinking for diabetes. Because I think when I started diabetes care, studies like the UK PDS, the United Kingdom Prospective Diabetes Study, were pushing out a sort of message that once you got diabetes, what you were on a steady decline with your beta cells, and it was a progressive disorder. And I think the importance of things like the direct trial is that what it shows is that if you get in early and you hit it hard with weight loss, and it's not a simple thing to do, that actually you can reverse this condition and you can get rid of it. Now, will it come back with time? Will it come back if people regain the weight? Yeah, possibly. But it is a message of hope. Mm-hmm. And then in terms of prevention for people with pre-diabetes, uncategorically the case that behavioral interventions which target essentially 5 things, normalizing body weight, increasing physical activity, changing diet in the sense of reducing the total amount of fat, reducing saturated fat, and increasing fiber. If interventions that target those things roughly halve the likelihood of progression from pre-diabetes to diabetes. So again, a message of hope. Now, how you do that and how you make those behavioral changes is essentially a matter of personal choice. I would say to a patient, when they say, "What should I do, doctor? Should I do this diet or that diet?" Or I think the answer is you should do whatever you're capable of doing, and whatever diet or behavior change you think you can sustain.
Mm-hmm. I don't know, could you comment on intermittent fasting? Because that's something I'm practicing myself. I kind of wanted to know your opinions on that.
So I think if you take a step back, I think we are, our metabolism has evolved to deal with particular food availability and particular physical activity patterns related to that food availability. So we would have probably, in times gone by, eaten quite a lot in the mornings, been quite active throughout the day, and then probably not eaten so much in the evening, and then gone to bed not on a full stomach, and then have the overnight period of where there was quite a prolonged period of not eating until the following morning. And for most of us, society has engineered it completely the other way around, so that we're now, most people eat their calories quite late in the day. They're often unrelated to physical activity. So if you eat your calories late at night, no physical activity afterwards, go to bed when you're meant to be switching your metabolism to a different sort of state, you're going to bed too full of calories, too little exercise. So I think of intermittent fasting as just one part of trying to turn that clock back to a different way of thinking about when we eat, when we don't eat, and when we eat and don't eat in relation to physical activity. Now, if intermittent fasting works for you, good. For somebody else, it might be better to say, I can deal with, how I lead my life by switching when I eat my calories to earlier in the day, or making sure I always go for a walk after having a meal. But again, it comes back to what fits in with your life and what you can sustain.
Thank you. Thank you so much. I do feel like now I don't eat much in dinner. So if I eat a big meal in dinner, so I feel excited. I can't go to sleep. So
Yeah.
I feel like after the meal, I need to consume it. Yeah.
But it, you know, there's been a big change in secular change in eating calories quite late, and then, you know, most people don't do anything after that. They don't. It's
Yeah.
no post eating exercise.
Yeah. Thank you. Yeah. Maybe
I will take the next one.
Yeah.
Nick, you mentioned that your view is on this particular topic of prevention through lifestyle management is one of the kind of big things which changed in the diabetes science over the last few years. Are there any other kind of big ideas which changed over the last 1 or 2 years, over the last 5 years when it comes to diabetes prevention or treatment?
Yeah, in terms of treatment, I do think the availability of novel agents that treat obesity is revolutionizing and will continue to revolutionize diabetes care. So, you know, the history of oral therapies for weight management is pretty checkered. You know, some of the early drugs, they might have affected appetite and therefore weight, but they often had central nervous system, side effects. And then there are agents that, block the absorption of fat in the gut, and they worked to some degree, but had pretty unpalatable side effects, because if you ate fat, it just goes straight through you. So in diabetes clinics, kind of people had thought, well, medical therapy for obesity is going nowhere, so let's switch to bariatric surgery as an approach. And I think the advent of a new class of agents, incretin-based therapies, really has changed the face of obesity management and diabetes care, and I think is probably going to continue. It's a totally different game than it was in the past. And the incretin effect is when you ingest, say, glucose, you see a change in your glucose levels in the blood that might be of that sort of level. If you intravenously inject the same amount of glucose, you see a much steeper peak. And the difference between the two is called the incretin effect. It's the same amount of glucose going into you, but it's having a different effect on your blood glucose. And that incretin effect is due to hormones that are secreted by the gut that have important peripheral actions. And this, the first class of drugs are the ones called GLP-1R agonists, and they are effective in diabetes. They're either injectable or can be taken orally, and they have an impact on appetite. They just give the participant the sense of being full, even though they haven't eaten a big meal. And so people just eat less because they don't fancy food so much. So people lose weight, and there's also an effect on the glucose levels that is partly but not totally dependent on the weight loss. And the pharmaceutical companies are now combining GLP-1R agonist therapy with other incretin therapies. So there's a combinatorial therapy for GLP-1R and something called GIP receptor as well, through an agent called tirzepatide. And I think all these agents will be tested And the evidence so far is that they give rise to weight loss in people with or without diabetes. And they give rise to a reduction in the complications of diabetes in those with diabetes. And in people without diabetes, reduce cardiovascular risk. So this is a very important moment in metabolic science and diabetes care. One of our problems has been clinically, we've been unable to get hold of enough of these agents because some of the companies didn't focus enough on the supply chain. But that's going to get remedied. And then certainly in the United Kingdom, but maybe elsewhere, the question is going to be, who do you give it to, and for how long,
right?
And what do you do when
After that? Yeah.
So those are the big questions.
Yeah,
Okay.
I just wanted to ask you, like, usually how long do people put it on GLP-1 agonist? And then I hope it's not lifelong. But after they're off the drug, do they still get benefit, or yeah.
Great questions, Chung. So in the UK, that the line is that people should take them for 2 years because it's a rationing question.
Mm-hmm.
Some people are arguing that why would you stop it at 2 years if it's continuing to have a benefit in keeping the weight loss off? Because in general, if you stop the therapy, people's weight on average tends to rebound. Not in everybody, but on average. And if they have effects that are beneficial for long-term outcomes that are only partly mediated by the weight, there is an argument for saying, well, maybe longer therapy is warranted. After all, that's kind of what we've done with statins. It's not like we give a statin when the cholesterol normalizes.
Right.
We say, okay, let's stop it.
Yeah. Nice.
So in the end, it will come down to a decision about affordability and about absolute risk, because the benefit of any treatment is a function of how much the risk is lowered, but also from what level. So you see the biggest benefits in people who are at high absolute risk. So I suspect that we'll have a discussion in the UK and elsewhere about who should get these therapies, how long for, and there will be a discussion about should they ever be stopped in some people.
Mm-hmm.
Okay, thank you. And Chong, I think you had a question kind of related to other medicines, yeah? So do you want to go with your next question?
One of the common used medication for diabetic condition is metformin. There have been quite an amount of study about metformin can also be an anti-aging pill. There's a lot of beneficial outcome after people taking metformin. So just wanted to know your opinions on, can we treat people, non-diabetic people with metformin? What will be the risk on that?
So what is the risk is probably quite small. So some people can't take metformin because it has a gastrointestinal side effect, which in some people is quite severe, but it's only a small percentage of people. And there are modified release forms of metformin which reduce that likelihood. There's also a hypothetical problem with B12 levels. So if you take metformin, B12 levels go down slightly. So, but it's not a major problem. The flip side is, what is the benefit? And to my mind, that's the bit that we have to focus on, because I think when you are treating a patient who's got a specific disease, you have to think about benefits. But when you're knocking on somebody's door and saying, I'm going to offer you a treatment for prevention, they're not a patient, right?
Yeah.
You're turning them into a patient by offering them a treatment. So you've got to be really sure what the benefits are. Yeah. And so drugs for prevention, you have to really test carefully.
Mm-hmm.
And there have been trials of metformin against placebo. And in the biggest one, which was done in the United States, people with pre-diabetes who took metformin compared to placebo, there was a risk reduction. It was about 25%. Remember that the lifestyle intervention in that trial gave a 50% reduction. So lifestyle was better. Metformin was quite good, but not maybe as good.
Mm-hmm.
But it was stopping progression from pre-diabetes to diabetes. And in my book, that is important, but it's not enough for me to go and knock on somebody's door and say you should take this medicine, because that person doesn't feel any different, right?
Mm-hmm.
Person with pre-diabetes, diabetes, what's the difference?
That's right. Yeah.
So I think the problem with metformin is we haven't done big enough trials with hard clinical endpoints.
Right. Yeah.
And then you ask yourself, why is that? And why do you think that is?
Well, there's a bunch of aging researcher trying to wanted to use metformin as a type of drug to treat aging-related diseases.
But I guess the question is, why hasn't anyone done a big cardiovascular outcome trial in 20,000 people?
Yeah, there's I think there's a funding that I don't know. Actually, I don't know. I know there's a small trial.
No, there is. The real reason is who stands to benefit.
Exactly. Yeah.
Because the drug is so cheap.
Yeah.
Because it's off patent, it costs next to nothing, right?
Exactly.
So no drug company in the world is going to fund that trial.
You're absolutely right. Yeah.
So in my book, governments need to do it.
Yeah.
But nobody. We tried to get them.
Oh, really?
In the UK to do that trial, but they declined. It's a bad mistake.
I see.
Because I think the people, I wouldn't. You asked me, would I advise it to people without diabetes? And the answer is not really, because I think we need to do big trials, because I think when you're offering drugs for prevention, you need to be really sure that you're helping people, because you are offering them help. They didn't ask you for it.
Yeah, correct. Yeah. In the US, I know Professor Nir Bazilai from Albert Einstein Institution, he started some small clinical trial using metformin. Yeah,
there are several of those. In my opinion, none of them are big enough.
Yeah, there's small trials.
Yeah, they need to do them bigger.
Yeah.
Okay, thanks. Nick, to build on the topic of prevention, as our audience is interested a lot in avoiding hypertension, and some of the viewers who experience sometimes spikes in hypertension, they also read about the associated risks of diabetes, and people get kind of pretty concerned, yeah? And so what's your advice to this audience who have not been diagnosed formally with either hypertension or diabetes, but they feel they are edge cases? What would you say? What would you advise to these people?
So there's a lot of commonality between hypertension and diabetes, hyperglycemia. So people who have diabetes often have hypertension, and people with hypertension often have diabetes. And when we look at both conditions, there's what's diagnosed, but there's also what's undiagnosed. It's like an iceberg. So, diabetes is commonly undiagnosed, but is prevalent. And the same is probably true of hypertension. So if somebody has got treated hypertension, it is a risk factor for them having diabetes. So it's in all our risk predictors for diabetes. And I would say probably someone with diagnosed hypertension who's on treatment probably ought to have an HbA1c test to check their diabetes,
Mm-hmm.
especially if they're older, especially if they have other risk factors. I think you were getting at the question, what about someone who's not got diagnosed hypertension but might have elevated levels? So I think they probably need to first check whether their blood pressure needs treatment. And secondly, probably there's an argument for estimating their risk of diabetes and deciding whether they have a test for diabetes as well, because they're quick and easy. It's not difficult to do. So there are risk calculators that are online that people can do. Diabetes UK does one. It puts parameters into a model like age, sex, family history, other treatments, etc., and calculates your 10-year risk of diabetes, and that can be used as a vehicle for getting tested.
Okay, got it. Thanks. So we're kind of gradually moving to the topic of prevention, and
Sure.
so sometimes it can be a bit controversial based on what I read in the news. So what's your take on prevention for diabetes, including the genetic screening?
Okay, so I think that we need to have a balance of investment. So we need to, people who have diabetes today, we need to optimize their care and deliver the best care possible to reduce the risk of complications. And in many healthcare settings, we're not doing that. So that's really important that we do that. There's a group of people with undiagnosed diabetes. So they have it today, but we're not finding it. So I think there are ways of estimating risk and implementing diagnostic testing with HbA1c and finding diabetes early. So because having it undiagnosed for several years is a bad idea. So we need to implement early testing programs for people to find the undiagnosed. Now you come to the question of prevention. So I think we need a mixed approach to prevention. So I think we should implement programs that we know to be effective. So I mentioned already the US studies, the diabetes prevention program, and particularly one in Finland, which show that behavioral interventions halve risk of diabetes. So in the UK, we have set up a national screening program and then a national diabetes prevention program, which rolls that out in the real world. It doesn't do quite as well as the trials, but the real world never does quite as well as trials, but it does pretty well. And there's evidence now emerging in the UK that that program is not only beneficial for those people, but overall in the population, it's probably giving rise to a small decrease in the number of new cases of diabetes. So that's a plus. Now, in addition to all of that, I think we have to recognize that approaches that try and find people at risk and then deal with the problem of diabetes one person at a time are never going to be sufficient for this as a public health problem. So in addition to doing the diabetes prevention program, individual approaches, which I absolutely think we should do, we also need to go a little bit more upstream and say, how do we turn the tap off of new cases by not seeing this as an individual problem, but by seeing it as a problem for the whole of society. People who are overweight are not overweight through individual choice. They're overweight, at least in a major part, because they live in a society where calories are cheap and easy to come by, and where, for various reasons, society has engineered physical activity out of people's everyday lives. So we need to see diabetes care as a medical problem, and that's fine. But we also need to see diabetes prevention as a public health problem, and it's a public health problem for which the solution isn't only individual level interventions. It's trying to think, how do we actually make societal change such that it's easier to eat healthier food, it's cheaper to eat healthier food, and the way we organize the structure of our society, be transport, leisure, work, is done in a way that tries to engineer back into our lives some physical activity.
Okay. Just to build on this, based on your experience, because obviously you studied this subject very closely, are there any countries where the governments or society is doing a better job in engineering this approach to a healthier lifestyle, less calories, more physical activity than others?
Yeah, I mean, there are, if you there are some cities in the world where there's the way the transport infrastructure is configured, the layout of cities is much more conducive to physical activity. You only have to take a trip to Copenhagen or Amsterdam to see how it is possible that to have cities where the cars don't dominate, where it is possible to have health promoting forms of physical activity. But some of the change required is quite drastic. It's kind of easy, if you have a city that's grown and evolved in a way that's positive for health, that's one thing. But re-engineering the structure of society to change it back, to retrofit cycle lanes and to change cars, that's much harder. But I think there is progress. I mean, I said it at the beginning, I went to medical school in London in the 1980s, and there was no way that I would have ridden a bike in London in 1980s. Now there are many more cyclists. The road structure is changing. There are fewer cars. Things do change. Maybe they don't change fast enough, but I think it is possible.
Yeah, I agree with you. Actually, looking at London, and every time I go there, I literally see more and more cyclists on the streets, which I think is absolutely great.
All right. But the way these changes happen, the infrastructure has to be right. The risks to an individual of cycling are lower when there's lots of cyclists.
Yeah.
So you have to get like a mass change. You don't want to be the only cyclist in a city where everyone drives, right?
That's true.
That's
absolutely
kind of bad for you.
Yeah.
All right, John.
On the other side,
I think you had a follow-up question based on your own situation, right? Which you wanted to ask.
Oh, okay.
Yeah, I think follow up on that, the last question. Actually, I agree with you. Like, we're more aware of what we eat, the lifestyle, how that could change us, right? So, because in the beginning, I don't even pay attention to the ingredients when I buy stuff in the grocery store. But now, when I pay more attention, then I see it's really hard to find stuff at the grocery store without adding refined sugar. So yeah, if you're trying to stick that way, it's not much you can buy in a grocery store. But on the other side, like, people are more educated. They know better of what they could eat, what is healthy, what is not healthy. I think that's also a big progress for us.
Yeah, I think the thing you got to be careful of, though, is that in order to know more and understand and read labels, you have to have agency. So you have to feel that you're in control of your own life. And I think there are many people in society who have low agency, who if if food is expensive and you're have an inadequate income, you don't really have a choice. And
correct.
It is logical under those circumstances to find cheap and easy sources of calories. So it's not just a question of educating people. It's much more structural.
It's also availability.
Yeah, exactly.
And
affordability.
Yeah, affordability. Yeah, that's correct. My personal question is
please.
Yeah, I have a family history of diabetics. My father was diagnosed at the early 40s, type 2 diabetes. So right now, my fasting glucose is normal and my HbA1c is normal, but my after meal glucose is always higher than what is recommended. So I'm just wondering, like, what should I do for preventing myself getting a type 2 diabetes?
So, having a family history is an increased risk factor. One of the earlier questions that I didn't answer, Dimitri asked me, was about genetics. Is it worth getting screened? I mean, there are some rare monogenic forms of diabetes which increase risk a lot and run in families, but they present slightly differently, and so by monogenic we mean it's a single gene defect, and I would doubt that you have that in your family. That you tend to see if people have diabetes that comes on extremely early in life, and it's called MODY, and maturity onset diabetes of the young, and it tends to have an autosomal dominant pattern of inheritance. So amongst a family, roughly half of the siblings would get it. So I doubt if that's the condition in your family.
Maybe not that dramatic, but
not that dramatic. And in terms of other genes, we know about lots of genes for diabetes. Actually, in terms of them helping in terms of clinical practice right now, they don't add much beyond doing simple things like the HbA1c and all the other stuff. So then you come to the question about the abnormality that you're describing. And actually, I think it's quite common. So in our studies, we measure HbA1c, and then we might, in a population, do an oral glucose tolerance test. Now, that's not a meal, right? But it's like a standardized test of how you respond to glucose. So the fasting is often a late thing that changes. Our bodies are really well designed to keep the fasting glucose very close. And that's because, there's elaborate systems in the body. When you go to sleep at night, what the body wants is to wake up in the morning, right? So it does not want the glucose to go down overnight. So the system's very tightly regulated. So the variance in fasting glucose between people is quite small. And almost the first thing that we see that goes wrong is that 2-hour glucose after the standard glucose test is slightly higher than ideal. So the threshold for diabetes is in millimoles per liter, 11.1, which is, I think, 200 milligrams per deciliter for people who use those units. And there is this condition called impaired glucose tolerance, or IGT, which is when that 2-hour glucose after a glucose challenge is between 7.8 and 11.1, which I think in milligrams per deciliters is 140 to 200 to 200. Now, if your glucose is in that range, you are at risk of getting diabetes. And the question comes, what can you do about it? And how do you find it? Well, it sounds like you're measuring your own glucose.
Yes, I even use a continuum monitor,
Okay, so,
which is very helpful.
yeah. So you could do a home-based version of the glucose tolerance test. Have 75 grams of sugar, and see if you're in that IGT range. And then the thing to do is change those 5 behaviors that I talked about.
I'm trying,
and because they will reverse it.
Hopefully.
So I think this is one of those things in medicine that's quite common. So in our studies, about 3.5% of people have this, but they don't know about it, because if they go to the GP, the doctor, they measure the HbA1c and they go, oh, it's okay, it's normal, but it's missing this phenomenon, which we only pick up, or you've only picked up, because you've done dynamic testing.
Yeah, I'm glad that I did the continuous monitor, glucose monitor. Otherwise, I wouldn't know my post-meal is so high. Yeah.
I mean, the challenge is, that's great, and it tells you what's what, but you wouldn't want to do it forever, because it costs quite, they're not cheap. And so you might want to do it occasionally. Did you find it useful? I have patients who say, it's a revelation when I look at the continuous glucose monitor. I can see that if I move from my desk to have lunch, my glucose goes up after lunch. If I walk like to round the corner to get a brown sandwich or something and eat, visibly the difference in glucose is massive.
I do observe that, similar to that. I testing whether should I go before meal, should I go for a walk, or after a meal. There's something different, but it's hard to control this experiment as well, because every day is a dynamic, right? There's so many parameters that could changes. So far, what I'm interested in that is that some food supposed to have high fiber, good carb, but sometimes it's very personalized. So for example, people say sweet potato might be good for you, high fiber, low GI, but for me it's horrible. I cannot have sweet potatoes. It just really spiked me. But I think it's personalized. If you wanted to find what spike you the most, I think this device is very helpful. I'm trying to figure out what I can eat in terms of a good carb.
But I think that's important and very good and personalized. I guess what one has to remember is glucose. The glucose now is only one part of a risk, prediction, because it's glucose averaged over all time that matters for risk. And the other thing is, I would say this, glucose is important, but it's not the only measure of risk that relates to our diet. So you could become totally obsessed with glucose levels and then end up eating a diet that was really bad in terms of fat, and
that's right.
was bad for your cholesterol and cardiovascular risk. So we need to be holistic in our thinking.
Yeah, totally.
It's actually very relevating for me and my wife to wear CGMs at the same time, because we figured out very quickly that we ate the same meals, obviously, but the glucose response was totally different. And so I'm much more sensitive than she is.
Okay.
And we said, hey, darling, we need somehow to adjust the diet and cut sugars, because it's not gonna be good for one of us, at least.
No, sure. I think these things are, useful and informative for people. There's a lot of things in medicine where empowering people to quantify things about the self is really important. And the same is true of physical activity. And you can be very inactive, but if you quantify it, knowing that has, for some people, has an impact on their motivation to change behavior. Not on everyone.
Yeah.
I
Nick, we're
believe in
running-
this.
yeah.
Sorry, I believe in this notion of like the quantified self. I think it's quite important.
It's a good one, definitely. Nick, I guess last question before we run out of time.
course.
Is there a particular myth about diabetes which really frustrates you and you want to use an opportunity to talk about it?
Probably not than one. More than one.
I think the thing yeah, there probably are. Whether it's a myth or a misunderstanding, I rebel quite a lot when people refer to diabetes as a lifestyle disease.
Mhm.
And it's the word lifestyle. So I think that when you take a step back from that, I know what people mean, but a lifestyle is something I choose to do. So, and it implies, by saying that diabetes is a lifestyle disease, implies that the behaviors are important in predicting disease and are part of, which are true, but it also implies that people's behaviors are a function of their choices. And I don't think that is wholly true. I think if you live in a society that, as we've talked before, is through the nature of employment, through the distribution of wealth, is such that people have an unequal chance of being active and eating well, I don't think those are a matter of personal choice. So I think we should talk about diabetes as a disease that's, you know, partly genetic but partly related to behaviors, but not go the next step and say it's a lifestyle disease, because it puts the responsibility on the individual. And I think we are all individuals who live in particular societies, and how we live, how we behave, and the risks and the diseases we get are a function of that.
Yep. Nick, thanks a lot. It was an exciting discussion, and we really appreciate you taking the time. It was great to have you here.
Thank you both. Enjoyed it.
Thank you so much. It's nice chatting with you.
Good. Thank you.